Assalamu alaikum. We'll start today's session. We have patient female Lisa, 40 years old, complain with fatigue. We will start after the timer. Okay, Dr. Imaz, are you there?
Yes.
Let's start. Hello there.
Hello.
This is Dr. Mukhtar, the doctor in the clinic today. May I confirm you are Mrs. Lisa?
Yes, that's me.
You are 40 years.
Yes, doctor.
We are here to discuss about your health condition. Is that okay for you?
Yes.
Can you tell me more about your complaint, please, Mrs. Lisa?
Sorry, yeah, my internet just, I don't know what
It's
happened
okay.
really. Okay. So, yes, I'm 40 years old.
Okay. Tell me about your complaint. What you brought you today to the clinic?
Um, I've just been very tired recently, doctor, and just
Okay.
can't do anything.
I'm so sorry to hear that. Can you tell me more about your tiredness? When did it start?
Yes, it started like 6 months ago, and it's just been getting worse now.
So you tell me now it's worsening day after day.
I'm
Is
sorry?
it is it worsening day after day?
Yes.
Okay. Ms. Lisa, when the timing of this, any particular time of this weakness or feeling tired
No, I'm just tired all the time, doctor. All the time.
all the day, this no particular time in the day.
No.
Okay. And what improve this tiredness? What do you think?
Nothing. Maybe lying down or resting, but sometimes it just doesn't get better.
And what worse it? The activity?
Maybe, yeah.
Okay. And along with this tiredness, do you have any rising body temperature?
Um, I might feel, yeah, I feel just tired maybe, but not actual fever, no.
Okay. And any change in your weight? Did you lose your weight?
I've lost some weight, yes.
Okay. And do you feel any lumps or bumps in your body?
No,
And any night sweats?
no.
How's your appetite?
It's not the best thing, doctor.
Okay.
I
How's your
find
diet?
difficulty swallowing sometimes.
Okay. Can you tell me more about this difficult swallowing, when it was started?
It's just vaguely started around the same time, and it's just I find difficulty swallowing the food. Sometimes it's stuck.
Is it food only or liquid and food?
Everything.
Everything. Okay. At the start of swallowing, or you feel it in the mid of your chest or at the tummy, this difficulty, you feel shocking.
Yes. Sometimes, yes.
So while eating and chewing in the mouth, you don't feel any difficulty.
I feel tired, just tired, but no.
Okay. And the food, you feel the food stuck in your chest.
Um, yes, sometimes, yes, but I find difficulty swallowing it, the actual
Mm,
act of swallowing, and sometimes it get is stuck in my chest, yes.
okay. The solid and soft or
Uh,
liquid,
yeah, sometimes both.
all. Okay.
Yeah,
Along with this, any mouth ulcers or mouth sores.
no.
Okay. Any feeling sick?
No.
Any throwing up?
No, not really, doctor.
Any change in your bowel habit, either loose motion or hard stool?
No.
Any blood coming from your, sorry for this question, from your back passage?
No.
Did you throw up blood before?
No.
Anyone told you that you look paler than before?
They told me I look ill because I've lost weight and I look tired all the time.
Okay. Do you look also yellow in your eyes?
No.
Any tummy pain?
No.
Any tummy distension?
No.
Any skin rash?
Yes.
May I know where exactly this skin rash?
Um, in my hands, let me show it to you.
Yeah, please. Any
Okay.
any joint change?
I'm sorry.
Any joint pain?
I get pain sometimes in my joint.
Okay. And any skin rash in your face to the sun when you exposed to the sun?
Um, no.
Okay. Did you share the photo of the skin rash? Any headache?
No, doctor.
Any weakness in your body or
Yeah,
in your
my
arms?
a lot of pain in my muscle, like in the flesh. And sometimes I just feel like weak. Yeah.
Okay. Any difficulties of combing your hair,
Yes.
climbing the stairs?
Yes.
Okay. Apart from this, any chest pain,
No.
any joint pain? Sorry,
No.
any heart racing awareness?
Yes, there is joint pain, but no heart racing. No.
Okay. Can you tell me about the joint pain I asked earlier? Where exactly the joint pain?
It's just it's just
What
all
joint?
over
In the
my
hand?
doctor. It's pain all over my joints, pain and stiffness. But I think my main problem is the pain is in my muscles.
Okay. And do you notice the stiffness in your hand worse with the wrist?
No. Sometimes,
With the
yes,
ac-
yes, doctor. Sometimes.
and it's lasting more in the morning while wake up?
It can just come randomly.
Okay. Any short of breath?
Yes.
Can you tell me more about that?
I just recently, like 3 weeks ago, started having breathlessness, but I don't think it's a big problem.
With activity as well.
It's mainly with activities, but I don't have shortness of breath if I'm sitting down
Any
or
cough?
anything. Just a little bit of cough.
Is it dry cough?
Yes.
Okay.
Yes, it's dry cough. Yeah.
Yeah. Any? Do you prefer any weather?
No.
Any change in your hand size or now and your shoe size, ring
No,
size or
doctor.
shoe size?
No.
Okay. Okay. Heart awareness. You told me there is heart awareness, right? With activity.
Yeah. Yes.
Okay. Any change in your water work?
No.
Okay. Sorry, Miss Lisa, for this question. It's sensitive little bit. Can I ask you about your period? Any change in your period?
Not really. No.
Okay. Any miscarriages before?
No.
You have babies.
Babies.
Yeah.
I have kids. Yeah, and they are in at uni. They're okay. No problems with the
Okay.
baby.
They are okay. And no eventful or delivery, any problem in the last delivery?
No.
Okay. Uh, any family history of skin condition?
No.
Any travel history recently?
No, doctor.
Any long-lasting disease I should be aware of?
Um, no.
Any over-counter medication?
I just take ibuprofen for the pain.
Is it by medical advice?
No.
Okay, and how frequent you are taking this?
Just once or twice a week.
For how long?
For 2 months now.
Okay, any allergy to the medication, to any
No,
medication?
not really.
Any surgery before?
No.
You have partner?
Yes.
You have any problem in the intimacy?
No.
Any dryness? Sorry for this question. Any dryness in your eyes or your private area?
No.
Okay. Sorry for this question, Miss Lisa. You have any casual relationships?
No.
Any time you share needles or take recreational drugs?
Oh, no, no, never.
Any history of tattooing or piercing?
No.
Blood transfusion?
No.
Okay. Do you smoke?
No. I used to, but I stopped now.
Do you drink alcohol?
I do, yeah.
How many units per week?
Six. Around six.
Okay. Um, what's your job? What do you do for living?
I stopped working now.
Is it related to your disease or your suffer?
Yes. Yeah. So
Okay,
because I'm always tired.
I'm so sorry for that. We can arrange some support for you if you need help.
Okay, thank you, doctor.
Do you drive?
I no, I don't.
Okay. Miss Lisa, I will examine you. Let me know what's your concern first.
What do I have, doctor?
Okay, so I will address the concern after examining you, starting by the any surrounding around the patient,
No.
the cachexia, any change in in the weight, I
Um,
mean the body build.
no.
She's fine. Okay,
She looks small, but you can't
it's okay.
tell. Yeah.
Okay. I will start by vital chart, blood pressure, blood sugar, temperature, and pulse.
Mm, normal.
Normal. Okay. I will see the hand now, the skin rash.
Mm-hmm.
I can see in the picture. I will share. Okay. So any pain there in the joint? I will examine the joint in the hand.
Yeah, sometimes I have pain in my hands.
Okay. And exactly where in this area?
It's just the back of my hand. Yeah.
Okay. This rash works with the time with the exposed to the sun.
I didn't notice, to be honest.
Okay. I will examine the joints. I mean, move and feel and
Mild
uh, I
tenderness.
yeah, there is any hotness.
No.
Okay, look, feel, move. Any deformity there.
No.
Okay. The movement. I will make prayer and reverse prayer sign.
Okay.
Any change or any sorry disability.
No.
Okay. I will go to carpal tunnel. Any carpal tunnel pain or affection in this area.
No.
The pulse.
Normal.
Miss Lisa, did you notice any change of your hand while exposed to the cold weather?
No.
Okay, proximal myopathy, move up and down. There is
Yes, positive.
positive. Okay, so let's go to the face. Any pallor or jaundice in the eye?
No. Slight pallor.
Slight pallor. Okay. The mouth. Any mouth sores?
No.
And the face. Any nasolabial rash?
No.
Okay. I will go back to the shoulder. Any neck swelling?
No.
In the shoulder, there is some muscle pain, right?
Yes, tenderness.
Tenderness.
Yeah.
I can feel exactly which arm or which area or which muscle, proximal.
Just generalized, a lot of tender points.
Okay. Uh, I will go now to the pulmonary examination. I will examine the chest, inspection and palpation, any scars.
No.
Okay, and examining of the hypertension, pulmonary hypertension signs in the heart.
No.
Detect the apex in place,
No, normal.
normal. Okay, any congested neck veins, any
No.
murmur.
No.
Okay, I will auscultate the back for any crackles.
You have 30 seconds left. No
Yeah,
crackle.
okay, no crackle. So back to your concern, Miss Lisa, what you have a condition might be autoimmune condition. Don't bother by the name. It's some disease affecting your defense, attacking your body in the muscle and in the skin, in the what's called dermatomyositis. Don't bother about this name. We will run some investigation and image to confirm your diagnosis. Then we will arrange a meeting with you to update you about the management plan. You have another concern?
Um, no, doctor. Thank you. Time's
Okay,
up.
time is up. Yes. Let's
Yeah.
start the presentation.
So, yeah.
Yeah,
What
we have,
was your case about?
yes, so Mrs. Lisa, 40 years old, came with complaint of fatigue, started 6 months ago. It's not related to the time, all the day, progressive with the time, and some relief while lying or taking some rest. In the history, there is some weight loss, not significant. Appetite is little poor. There is also difficulty of swallowing, positive history of difficult swallowing to all type of food, solid or liquid or soft. Uh, I couldn't appreciate any signs of SLE, no nasolabial rashes, no also no history of miscarriages, so I rule out SLE. Again, back to the finding in the history, there is skin rash in the hand, mainly at the back of the dorsum of the hand, some painful muscle areas in the arms. By family history, negative, travel negative, and she took some medication, non-steroidal over-counter for the pain only. Positive alcohol history, however, it's in the social limit. So my differential diagnosis will be for dermatomyositis.
Okay.
Okay, and I could put also fibromyalgia, and I could also put LCD and mixed connective tissue disease. However, no signs and symptoms of SLE.
Okay. So, how are you going to manage this patient?
Yeah, so I will arrange an outpatient appointment for this patient to do general investigation, general baseline basic workup like CBC, inflammatory markers, kidney function, liver function test, coagulation profile, and I could expect some anemia of chronic disease in the CBC. Inflammatory markers I expect to be high, and I could do also CPK for muscle, and for the imaging, I could do joint X-ray to rule out any joint affection. I could do echo and chest X-ray to rule out any complication. I could do also barium swallow for the esophagus to rule out
What
any.
type of complication that you're looking forward to rule
Yeah,
out by the imaging?
yeah, the imaging for pulmonary fibrosis or by echo to rule out pulmonary hypertension, and echo for checking for heart failure signs or pulmonary hypertension.
Okay.
The other complication might be associated joint. I will do joint X-ray, and in case of there is swelling, I could do also aspiration. The test to diagnose the patient is to do muscle biopsy, and there is antibodies called anti-Jo and anti-MO to confirm the diagnosis. Anti-nuclear antibody as well. It will be mostly it will be
Anti-Joe
positive
and
in this patient.
anti-what?
Anti-MI, I think I remember anti-MI. I forgot the name, exact name.
Okay.
I think. Okay. Anti-nuclear antibodies as well, and I could do also other autoimmune profile to rule out any mixed connective tissue disease.
What else do you need to rule out?
To rule out Sjogren, to rule out antiphospholipid antibodies. However, it's negative history for miscarriages. SLE, I
Okay.
will do also anti-double strain, anti-Smith to rule out SLE, and
Mm.
anti-RNP for mixed connective tissue disease. The
Okay.
management, yeah, I will arrange a multidisciplinary team approach, including the rheumatology, immunology, and uh, rheumatology, respiratory, respiratory therapist, and SOL team, swallowing and language therapy team, uh, non-pharmacological patient counseling education, and counseling about the complication and the disease. Not pharmacological, I could start steroid for this patient in the acute attack, and for the chronic management, I could start steroid sparing agent and immunomodulating agent to control the disease.
Okay. Um, okay, time's up. So, so صح, you got the diagnosis right. It's was the dermatomyositis.
Dr. Maz, your voice disappear. Yeah, please, again, Dr. Maz. Dr. Maz, I guess he
Can you
has
hear me?
some connection. You have some connection error.
Yeah, sorry. Sorry, somebody's
Yeah,
trying to
yeah,
call me.
yeah. Start,
So
yeah, please, from the beginning. Yeah.
okay, so you got the diagnosis right. It was dermatomyositis. Um, the patient did have the dysphagia, which was an associated symptom with the
Mhm.
dermatomyositis. The patient also presented with breathlessness, which can represent the
Anemia.
interstitial lung disease because she had
Uh-huh.
cough.
Mhm.
But because of the weight loss, we could also rule out we might also need to rule out cancer because they can come with
Yeah,
very different types of cancer.
yeah, ovarian cancer. Yes, you're right.
Exactly. A
Yes,
lot of types. So pancreatitis, gastric cancer, lung cancer,
yes, yes,
um, all the
yeah,
types.
yeah,
Um,
you're right.
so we needed to rule this out because the patient had weight loss. Also, one of the most important blood tests is the creatinine kinase
Yeah,
because it's usually high. The AST, ALT, LDH, all these the muscle enzymes, they're usually high. Um, as you said, we will need to on investigation first. The patient came, we will investigate her. We will start by proving the diagnosis. So do the basic bloods and proving the diagnosis and making doing all the antibodies, even including the double stranded or anti the ANA rheumatic factor and exclude vasculitis as well because
mm,
of the mixed connective tissue disease. because the patient can come with mixed connective tissue disease with dermatomyositis, and because of that, excluding the cancer. So in the screening for the complications, we screen for PSA, CEA, C1, CA125, CA19, especially if the patient um, is over 65, because it's more than 50% that they will have cancer. If the
Yes.
screening is negative, then every 3 to 5 minutes, we will do this cancer screening.
Yeah.
Okay?
Every 3 to 5 years.
Yes. We will repeat the
Yeah.
cancer screening, all these blood tests.
Yes.
The antibodies are anti-Jo
Yeah.
and
Anti-G.
anti-La, and anti-Ro because of the mixed connective tissue disease as well. So
Mm-hmm.
the anti-Jo, what does it represent? If I found someone have anti-Jo, that means they high likely to develop interstitial lung disease. They will have mechanic hands, and mechanic hands is this rash. What's the name of this rash?
Cotron. Cotron
Gottron.
rash.
Exactly. Um, the management plan, as you said, salt, physiotherapy. We'll give them high dose steroid.
Mm-hmm.
Um, and then steroid sparing agents like methotrexate, والأذاثيوبرين, والحاجات دي, cyclophosphamide. The patient
Mm-hmm.
is coming with severe uh, breathing problems or difficulty swallowing or aspiration pneumonia, then we will give them IVIG or rituximab
Mm-hmm.
and treat the malignancy, because sometimes the malignancy might be the precipitating factor.
Yeah.
Okay.
Yeah. Thanks for
But
a nice
yeah, I
case,
think
Dr.
well
Ilyas.
done. Very well
Yeah.
done.
Thank
You
you.
took so much time in the history. I think you started
Yeah.
examining at like 10 minutes.
Mm-hmm.
Um, so the history is once you had a look at the rash, and I think once you look at the rash, you knew that it was Guttron papules, because you
Yeah.
started asking me about the dermatomyositis symptoms. Just rule
Mm-hmm.
out cancer. Ask for the red flags, which are dysphagia, breathing problems, weight loss, dry cough, exertional dyspnea. Rule out the mixed connective tissue disease, any other rashes, any joint stiffness in the morning, any rash in your face, as you did. But you don't have to ask detailed question like in the history station. You need to ask just
Yeah.
like 1 or 2 questions just to exclude every condition.
Yeah.
So that you can start, because examination, you will definitely need more than 5 minutes for the examination and the concern.
Yeah. Yeah. You're
But
right.
other than that, you did very well. You get the diagnosis, you get the differential, you got the investigations, and the management plan.
Thanks,
Very well
Dr.
done. Thank
Ilyas. Thank,
you.
thank, thank you so much. It's a nice case. And it's a common case, by the way, in the exam.
Yes.
Any autoimmune or rheumatology case is common. So we can take the other comments if anyone has comment or question.
I just want to say that
Look,
the first patient I saw her in my life, the dermatomyositis, the polymyositis, first polymyositis I saw her in my life was typical this story in 2019 maybe. 40 years old Sudanese lady who came with exertional dyspnea. She had this muscle pain all the time and nobody cared. Everyone kept saying, you have malaria, you have typhoid. And after I think 1 or 2 years, she gave up. But when she developed the exertional dyspnea, she had the CT
the
scan.
complication, yeah.
Exactly after diagnosing the interstitial lung disease, she was diagnosed with the polymyositis.
Mhm.
So, yeah.
You're right.
So
Yeah,
the
it's common.
complications are important. Yeah.
Yeah, very important. It's actually a spot diagnosis. But by the way, I didn't see the rash. I saw it late. That's why I was still keeping asking. But when I share the picture, that time only I saw the rash. When I share it to the screen, I don't know if you saw it or no. I guess I share it. I hope all of you saw it. If you want, I can share it again. So let's take the comment. Dr. Ruda said, "Yeah, examine. Yeah, I examine late. Yes, you're right, Dr. Ruda. I always examining late. I hope in the exam I will do my best to be early in the examination. So the differential, yeah, as Dr. Roda wrote, dermatomyositis, polymyositis, mixed connective tissue disease, medication, yeah, like yeah, you mean atorvastatin, yeah, can be myopathy, fibromyalgia. Breast cancer, I guess also ovarian cancer, Dr. Roda, is there also one of the complication, ovarian cancer and breast cancer. Yes, okay. Any question from others? Any question, Dr. Imaz, or any comments you want? Okay, Dr. Abbas, examination, Shawl sign, heliotrope rash, sorry, and V sign, what V sign? Gottron papule, yes, you're right. But what V sign? I'm not sure about V sign.
I will
Shawl
show
sign in the back. Yeah,
and في sign in
yeah,
the front, chest.
chest. Okay. Okay. Dr. Mahmoud, what the difference between mixed connective disease and overlap syndrome? We always mention this. And the mixed connective tissue will be positive anti-RNP, but the overlap, you will not find this anti-RNP, but you will find rheumatoid arthritis with other disease. This is the difference. So it's like laboratory diagnosis. If you have anti-RNP, it will be mixed connective tissue. But if you have mixing between rheumatology and other rheumatology disease or rheumatological problem, it will call or it will be named as overlap syndrome. This is common question. Fibrosis and GIT cancer usually common associated relevant sign there. Yes. Thanks, Dr. Tanvir. So any GI or let's say uh, female, I mean ovarian cancer or breast cancer, GI and ovarian and breast. This is the association. Plus the idiopathic or pulmonary fibrosis, and in the long term, it will be pulmonary hypertension due to fibrosis. Okay, any other question or any other comment? Okay, I will share the photo again just to show all of you the rash, the guttural papule. Is it clear now in the screen? Okay, let's go to clear. Okay, so sorry, doctor. We can, who's
Can I
asking?
give a hint about this overlap syndrome?
Yes, Dr. Dean, here you are.
Okay, yes. Overlap syndrome is called also anti-synthetase syndrome. Okay,
Mhm.
it's similar to polymyositis and dermatomyositis. There are symptoms like mechanic hands. There are featuring and cracking of the fingers. Okay, Raynaud's with myositis, arthritis, fever, and interstitial lung disease. The antibodies which are positive in this condition, anti-Jo, BL7 and BL12. This overlap syndrome or anti-synthetase syndrome. Okay.
Okay.
Okay, I can share with you.
Yeah, please. And different than a mixed connective tissue will be
Okay.
positive anti-RNB, yes. With another manifestation, what we know already. Yes. Yeah, please,
Yeah,
doctor.
this mechanic and
You share it
okay. I will share here or
later?
on
Okay. And
WhatsApp.
if there is picture, better, yes, in the WhatsApp group, then I will share it here to the screen. Okay, thank you, Dr. Dina. Yes, Dr. Ihda, your question. Dr. Ihda, yes.
Regarding lab testing, here only antigen or will be need to in a profile like anti-La, anti-Ro,
Yes,
like
what we used to do in our practice, whenever you have vasculitis or connective tissue disease, you will do all the screening of autoimmune antibodies and autoimmune screening. This is our practice in our life. I mean, just to rule out another association might be there and is still not symptomized on the patient. Sometimes you have SLE and still no, for example, no miscarriage, but by doing antiphospholipid antibodies, you might have positive antibodies, and the patient might have in the future a miscarriage. So screen for it, it might be positive. You got
yes,
the point. Yeah,
yes,
it's you will tell the examiner what's target and what's specific, but in the same time you will screen for other because you might have association which is that not yet symptomized on the patient. For example, Sjögren, sometimes also there is the complication of Sjögren, dry eye, and the patient didn't experience that, but still they are positive antibodies, anti-Ro, anti-LAL. So you will screen for all. I remember also one of the antibodies cross the placenta and you will screen for it. It can cause bradycardia. I guess it's anti-Ro. Someone confirm. Anti-Ro, the antibodies can cross the placenta and cause
Yes,
bradycardia for
yes,
the baby.
anti-raw, anti-raw.
Yeah. So we are screening for all. It might be positive and you might prevent further complication by this screening. Anticipate what will happen to the patient, Dr. Ida. This is the point. Because autoimmune disease is not coming as one disease, it comes as group of disease or association. Okay?
okay, thank you, Doctor.
Thank you, Dr. Ida. Let's have another question or comments. Dr. Dina's share. Yeah. Anti-sensitase syndrome, anti-Jaw syndrome, similar to polymyositis, dermatomyositis, antibodies, anti-Jaw, PL7, PL12, symptoms, interstitial lung disease, arthritis, fever, myositis, raynaud, mechanic hand, fissuring, cracking of fingers, how to differentiate primary, secondary node phenomena. This is for phenomena, raynaud phenomena, okay, primary and secondary. So this is what's called overlap syndrome, Dr. Dina, right? Anti-Jaw syndrome, anti-sensitase. This is the antibody. Okay. Thanks, Dr. Dina, for the sharing. Important to test, Dr. Rodad, important to test pain on temple for GCA, giant cell arthritis, fatigability test, and eye movement for myasthenia gravis. Offer at end PV per vaginal, I guess, per rectal breast examination. Look for other association, autoimmune disease, steroid face, carcinoid immune. This for the complication. Okay. Thanks all for, thanks Dr. Imaz for this nice case, and thanks all for your shares, your information, always appreciated. Dr. Imaz, are you ready? I will give you the scenario. Hello. Dr. Imaz, are you there? Our message here. Sorry for this. I guess she has some internet problem. We'll wait here for 2 minutes. If anyone want to ask any question, any comment. Okay, Dr. Mas joined. Yes, Dr. Amin, give question. Can you please give scheme for fatigue? So what I am doing in the fatigue, any fatigue scenario. First question, what you mean by fatigue? Tiredness or weakness, something CNS, I mean central nervous system, or something related to the body tiredness. So when you have CNS, you will analyze the CNS away from any rheumatology or any fatigability related to mixed connective tissue disease or whatever the reason. Now let's go to the tiredness. The tiredness, first thing you ask, onset, course, duration. This is what I'm doing. The onset you will know for a long time or short time, the course, worsening, progressive, and the duration and the timing in the day. This is maybe the most important question and the clue to your case. All the day long might be anemia or connective tissue disease. If the evening time only, you might think about myasthenia gravis. If in the early morning, as we mentioned 2 days ago by Dr. Dalia, early morning it will be like obstructive sleep apnea, difficult of sleeping due to obstructive sleep apnea, and he will be fatigued in the early morning. This is related to the timing. It will guide you. So we have three categories now. Early morning, obstructive sleep apnea, or at the evening after repeated exercise, myasthenia gravis. All the day long, it will guide you to connective tissue disease or anemia. Then you can screen for anemia by anyone told you you are paler than before. This is for anemia. Heart tracing, awareness of your heartbeat, short of breath while doing exercise. So this is anemia. So we covered the anemia question. Then what will remain? The connective tissue disease and the fatigability. The common scenarios, either multiple sclerosis, and you will have the other signs of multiple sclerosis like hot weather and weakness and unsteadiness, eye vision problem, double vision, uh, and so on, optic neuritis, and so on. This is for MS. What will be remained for you? SLE, dermatomyositis, and our connective tissue disease as a package. Whenever you have one of these, you should ask about all. It's common to bring patient with SLE, and you might have another complication or association of antiphospholipid antibodies. You might have rheumatoid arthritis, you might have Sjögren, you might have um, dermatomyositis, polymyositis, and finally you'll diagnose the patient as a mixed connective tissue disease. Don't forget the Raynaud phenomena. It's a very important question, either in the history or in the examination. This is the fatigue for me. I hope it's clear, Dr. Amin, for you. So also Dr. Abbas, share about the fatigue. Yeah, almost the same. Morning OSA and CO poisoning. Yes, one off. But CO poisoning will be as acute one. He will be presented within hours. But for the long term, will be our obstructive sleep apnea or the other differential. You can share. You can see the screen now. Okay, it's in the chat box. Evening time, myasthenia gravis, anemia, chronic fatigue syndrome. Yes, I missed this point. Chronic fatigue and fibromyalgia. This is very important. Patient will be present with fatigue and lymphadenopathy, memory problem, sleep problem, sometimes sore throat. It will for more than 6 months. This is the definition. So this is chronic fatigue syndrome. Fibromyalgia, it will be muscle pain, tender point. However, the numbers of these tender points. All day, all the day long, weight gain. Yeah, either by weight gain or weight loss. So weight gain will be hypothyroidism, Cushing, pseudo-Cushing, acromegaly, simple obesity or metabolic syndrome, polycystic ovarian syndrome. If the weight is decreasing, so weight loss or neutral, you will think about three C's: cancer, chronic infection, connective tissue disease. Malabsorption, like celiac, Addison, hyperthyroidism. Okay, this nice figure. I can share it to the group, or Dr. Abbas, can you share please to the group? It's nice one. Almost the same what I mentioned, but here he mentioned weight gain and weight loss. So you can think about other endocrinology disease like hypothyroid, Cushing, and pseudo-Cushing, and acromegaly. If weight loss, you will think about connective tissue disease, malabsorption, and you can add also cancer. Thanks, Dr. Abbas. Dr. Zain, if Dr. Imad is not available, can I take her case? Appreciate it. Yes, sure, but let me confirm if she's not here. Dr. Imaz. Dr. Imaz, are you there? I will message her for the last time. She can take the case, or otherwise I will give it to you.
Hello?
Yes.
Yes.
Dr. Imaz, you are there?
Yes.
Any
Sorry, yeah,
connection problem?
I had a connection problem. I had to
So
log in
so
through
it's
the laptop.
so it's okay now. You hear me
Yes.
well?
Fine. Yes.
Okay, take
Can
your
you hear me?
patient. Yeah, clearly now. Mr. John, Mr. John,
Yeah.
he's 40 years,
Yeah.
came with foot pain,
With
foot
what?
pain, foot pain, foot.
Okay. Can you give me 4 minutes then?
Why? Because of the foot?
No. But because I have guests, I
Okay,
have to kick my guest out. So I'm
okay,
sorry.
okay. We'll wait for you. Sorry, Dr. Oda, I will give you tomorrow long. I promise, because it was your turn initially, but you apologize, so I will compensate for tomorrow. Thanks. Okay, ready? Dr.
Okay, I'm
Iman?
sorry. Yeah, let's start.
Yeah, yeah, let's start. Yeah, here you are.
Okay, hello.
Hello.
Hello, hi, good evening. This is Dr. Tukawi. I'm one of the doctors in the clinic today. Am I speaking to, can you confirm your name and your date of
Yeah,
birth, please?
I'm John, Dr. John.
Hi,
Call
Mr.
me
John.
John.
Okay,
Yeah.
hi, Mr. John. And you're 40 years old.
Yes, I am.
Okay, so Mr. John, what seems to be the problem?
Doctor, I have severe pain in my leg.
Mm-hmm.
I
You
cannot
have the
tolerate it
pain in your
anymore.
leg. Okay.
Yeah.
Yeah, and when did the pain start?
Actually, yesterday, doctor, it's
Okay.
so agonizing pain, doctor.
I'm so sorry. Do you think you might use some, do you want me to prescribe some painkillers for you?
Yeah, doctor, please. I already talked yesterday, but I guess the effect already expired.
Okay. Are you allergic to any medication?
No, doctor, I am okay.
Okay. What did you take yesterday?
I took some Fivadol.
Which is it paracetamol?
Yeah, paracetamol.
Okay. All right. Let me just ask you a few questions and we can
Yeah,
give you painkiller, definitely. Okay?
thank you.
Okay. So tell me about the pain. It started suddenly yesterday. Did you have it before?
Yes, doctor, I have it 6 months ago,
Mm-hmm.
and I took some painkiller. Then the pain improved. Then I just forget what to do, and I left it.
Okay. Do you remember what was the painkiller?
That time it was ibuprofen.
Ibuprofen. Okay. And was there any swelling?
Yeah, doctor, you're right. There
Mm,
is.
okay. Can I see your foot by any chance?
Yeah, doctor, I will send it to. Yeah, you will see it.
Okay. Okay.
Okay, doctor, go ahead.
So meanwhile, was there any redness with it?
Yeah, doctor, you're right.
Mhm.
There is redness.
Okay. And when it happened 6 months ago, it was red as well. Is it the big toe or the whole foot or ankle joint?
No, doctor, it's related to my big toe, and it wasn't like this, but yeah, it seemed like this.
I'm sorry, can you explain this to me?
Yeah, I mean the previous attack wasn't the same like this. I
Mm,
mean the intensity of the pain wasn't like
mm.
this.
Was it less?
Yeah, it was less. Yes.
Okay. And is it the same pain, the same place and everything?
Yeah, same, doctor.
Do you have any pain anywhere else in your joints? Any other
No,
joint?
doctor.
What about the
No,
hands, the fingers?
no, no.
Okay. What about rash? Any skin rash?
I no, I didn't see doctor. Any
Okay.
skin rash.
All right. Any fever with it?
No,
And did you hit your foot with anything? Do you think there was any
no,
trauma? Not before this
no,
time and not before the last
no,
time as well, 6 months ago? Okay.
no,
And what about other symptoms like tiredness? Have you been tired recently?
no, doctor. I'm okay.
No tiredness, no joint pain, sorry, no other joints pain and no rash at all. No rash when exposed to sun.
Actually, not the sun, doctor. I noticed in my hair, doctor, some rash.
Okay, you had some rash in your hair. And is it scaly rash? Can I see the rash as well? Can I see your foot and the rash, please?
Yes, yeah, yes. It was yes, Haley, doctor. Yes, you're right.
Okay.
I will. Yeah. Okay.
Are you gonna send me pictures or
I send, but I will share just to be more. Okay.
okay. All right. I'm just gonna ask you further questions. So with this pain, did you notice any stiffness at all?
No, doctor.
No stiffness.
Yeah, here you are, the leg picture.
Okay.
You can see
Mm-hmm.
it.
Yeah. Yeah. It looks very red.
Okay.
And
This is the
swollen.
head.
Yeah. And this is the
Yeah.
head. Okay. And since when did you have this rash in your head?
Since long time, doctor. Maybe more than 5 years now.
Okay. Is it itchy?
It's not doctor, but I took some medicine by my GP for
Mm,
this rash.
And did they tell you the name of the condition? Is it psoriasis?
Yeah, I guess so.
Okay. All right. What about stiffness? Did you notice any stiffness?
No, doctor.
No stiffness. Okay, so let's
Mm.
go back to the rash. You
Mhm.
had this rash years ago, and what medication are you taking for it?
I'm taking methotrexate, doctor.
Methotrexate, and do you think it's helping?
Actually, doctor, I didn't see any effect. That's why I stopped.
Okay, and did you notice any sore throat or any infections, flu symptoms
No,
recently?
doctor. I'm not taking it anymore.
Okay, any breathlessness?
No,
Okay, why are you not taking it?
I didn't notice any effect.
No
This is
effect.
the rash, yeah, the same,
Mm,
and now I'm suffering more because of this
okay.
joint
Is the
pain.
rash okay? I'm really sorry about this. So we're gonna
Mhm.
try to get to the bottom of
Ah,
this. Is the rash oozing at all?
no, doctor, just scale.
Any bleeding in this rash?
When I scale it,
Okay. Is it itchy? Do you scratch it?
sometimes, doctor, but not always.
Okay. All right. And do you have the rash anywhere else other than your scalp?
No, only
Behind the
this, doctor.
ears? What about your
No.
nails? Nail changed?
Yeah, I noticed, doctor, but
Mm,
it's okay, doctor. I can tolerate it. It's not much affected.
okay. No, so I'm asking you because this might be related to your
Mhm.
condition.
Yeah,
What about other symptoms? So what about your bowel work?
it's okay, doctor.
Your bowel work is fine. No diarrhea or
No,
constipation.
no,
No epigastric pain, like for example,
no,
heartburn or
no.
dyspepsia. What about
Mm.
water work? Is it normal as well?
Yeah, same, doctor.
So
No
no
change.
discharges or any change in the color of the urine.
No,
No blood in the urine.
no,
Okay. And any eye symptoms, eye redness, for example,
no,
eye pain.
no,
What about weight? Did you notice any weight gain recently?
no, doctor.
What about high blood pressure?
Uh, I was diagnosed before, doctor, with high blood pressure, and
Okay.
my GP gave me some medicine.
Okay. And is it controlled?
Yeah, I guess nowadays, yes,
Mm.
140, 90.
Okay. What about high blood sugar?
No, doctor.
No high
I'm
blood sugar. And you didn't notice any weight gain or anything or a weight
no,
loss? Okay. Okay.
no.
Good. So now I just need to ask you further questions as well. What about your job? What do you do for a living?
Yeah, I'm taxi driver.
Okay. And is this affecting you?
Yeah, I cannot do in my leg any activity
Mm.
by my foot.
I'm sorry. We will try to figure out a way to help you. What about smoking? Do you smoke, Mr. John?
Yes, yeah, 10
Okay, how many
cigarettes per day.
cigarettes or for how long? Okay, for how many years?
10 years.
Okay, so it might sound a little bit not related. However, smoking can have a direct effect on your health. So I highly advise that you stop smoking, and I can refer you to the smoking cessation clinic. Would that be okay?
Sure, doctor.
Okay, what about alcohol?
Yeah, I'm drinking
How much?
about 14 units per week.
Okay. Yeah, I think 14 units is the maximum level where it's healthy. More than that, it's gonna affect your health definitely.
Uh,
Did anyone tell you that you look yellow?
no, doctor.
Anyone told you that you look pale
No,
and no sweating,
no,
no lumps or bumps?
no,
Okay, I'm gonna start examining you, and I might ask you a few questions meanwhile. So, looking at him, does he have any walking stick or anything?
no, but he's limping while moving because of
Okay.
severe pain. Yeah,
Okay. So I'm gonna start by examining the joint, hot and
yeah,
tender to touch. It's very
yeah.
red. Can we move it?
Yeah, a little bit limited because of the pain.
Okay. Is there any effusion?
And no, but it's hard.
It's hard.
Yeah,
Okay. And what about the ankle and the knees? Any other joints swelling or redness?
nothing affected. No, only this
Any
two.
deformities in the hands?
No,
No deformities in the hands, no skin rash in the hands, but the nails, there
no.
are changes in the nails,
In the hand only.
in the
Yeah,
hands.
in the hand there is some nail changes.
Brittle nail. Okay.
Yeah,
What about smoking, tar smoking?
no, it's not there.
Okay, I'm just gonna look generally for the between contraction, any thinner or hypothinner muscle atrophy,
No.
any deformities or swelling. Examining the wrist just randomly, very subtle, in a subtle way, moving the wrist. Any pain or tenderness, Mr. John?
No.
Any proximal weakness in the shoulders?
No. No.
Eye, any pallor, redness,
No.
jaundice?
No. No.
And the face, any rash?
Uh, in the
The rash
face,
is
no
in the
rash.
head, but no rash.
Yeah.
Okay, so in the
No.
head, the scaly rash, the one that I saw in the picture,
Yeah.
it's not
Yeah.
oozing or bleeding or anything. It's just a dry scaly
No.
rash.
Some
Okay.
scales is there. Yes.
Okay, what about the mouth? Can you open your mouth for me?
Yeah. Nothing. No rash. No sores.
I'm sorry.
No sores. No rash.
Okay,
In
and
the
then
mouth.
the neck for any ulcers in the mouth? No ulcers, you said.
No
Neck for
ulcers.
lymph
No.
nodes,
No
listening to the
lymphadenopathy.
chest, fine
No.
crepitations, air entry,
No. It's
hip
okay. All chest examination and cardiac examination is normal.
are normal. What about the abdomen? Any signs of ascites or
No stigmata of chronic liver disease at all.
does the patient generally have a high BMI?
No, he is moderate. He's not
Moderate.
overweight. Yeah.
Okay. Okay. So, Mr. John, can you tell me about your family? Is there any family history of any similar conditions?
Yes, my father was having rheumatoid arthritis disease.
Okay.
Mhm.
And was he on treatment for that?
Yeah.
Okay. What about your history? So I know that you have the high blood pressure and you have
Yeah.
the psoriasis in your skin. Anything else? Any other medical condition?
No, doctor.
Are you taking any other medication at all?
Yeah, you mean for the high blood pressure,
In
doctor?
general, yeah. What do you take for the blood pressure?
Yeah, I took what's called thiazide,
Right.
doctor.
Okay. All right. And what about any allergy? Are you allergic to any medication?
No.
No, you're not allergic. Okay. Any over-the-counter medications other than the ibuprofen?
No, only that, doctor, when I feel the
How
pain.
often? How often do you take it?
Yeah, it's occasionally, doctor. It's not
Okay.
usually, but when I feel severe pain.
Mm. Okay. And what about uh, how is the disease affecting your social life? How do you feel at home? Are you
Doctor, if
able to carry your
I can only, doctor, but my problem now with driving, I cannot,
mm,
because of this pain, I cannot even
mm.
drive my taxi.
Okay, I can see that you struggle. So do you have any other concerns other than the disease affecting your driving?
Yeah, yeah, doctor. Is it rheumatoid arthritis like my father?
That's a very valid question. So, Mr. John, you have the skin condition, which is called psoriasis, with all the nail changes that are typical. You also have this swollen big toe that comes and goes. That happened 6 months ago, responded very well to ibuprofen, and now it's very swollen and red and hot. You have been started on thiazide. When did you start the thiazide?
I'm diagnosed hypertension, doctor, since 5 years now.
But when did you
But
start the thiazide?
yeah, since I was diagnosed with the
Okay.
high blood pressure.
All right. So this is probably related to the thiazide. It can be. It can also be psoriatic arthritis. And we need to rule out rheumatoid arthritis. Rheumatoid arthritis is the least likely diagnosis here. We need to admit you to the hospital. We need to get the one doctors to have a look at you. We need to do some imaging and some blood tests and give you some painkillers to help with the pain. Regarding the driving, I can't promise you. I don't know. Do you work for a company or?
No, my own taxi, doctor.
What I can do is I can refer you to the social workers. Maybe they can have ideas and options to help you. Would that be okay?
Sure, doctor. Thanks for
Okay.
this
Any further
support.
questions?
Yeah, doctor. Will you admit me, doctor, because I have severe pain?
Yes, so as I said, we will admit you, we'll do blood tests and imaging, scanning, we'll give you painkillers. Uh, uh, I advise you to stop smoking and cut your drinking down. And time's up.
Okay. Okay. Thank you. Let's go to the examiner.
Mhm.
I will just reset the timer. Okay, start. You can see the time.
Yeah.
Okay, start. What's your case?
So this is a 40 years old gentleman with history of recurrent uh, metatarsal metatarsobpharyngeal joint inflammation in the form of redness, hotness, and tenderness and swelling. He have history of psoriatic arthritis, which is not controlled. He doesn't take the treatment for it. He was started 5 years ago on thiazide. We need to rule out gouty arthritis. It's least likely because he's been on it for 5 years. However, we need to rule it out. I believe the patient needs to come in. We need to do at least the basic blood test, full blood count for infection markers and for anemia, renal function test, the liver function test as well. We will need to have uric acid, X-ray to the big toe, probably aspiration if there is any effusion in the big toe. The patient needs to be also have a lot of other blood tests to make sure that his blood pressure is controlled. Probably need the thiazide to be changed if he's proven to have gout. And he will need some social support and with his work as well. Not to mention that he need to be referred to TNO, a rheumatology consultants and a dermatological consultant as well to control his condition. He also, as I said, need to be treated in a multidisciplinary way. The GP need to be involved and a community nurse need to be in the picture as well.
Okay, so what's your how you manage this patient? You
Yeah, so
mentioned the investigation, right? Okay, before the going to the investigation and management, what's your differential?
my differential, so it's gonna be gouty arthritis versus psoriatic arthritis.
Gouty and psoriatic, and give
Yeah.
me one more.
Septic arthritis as well, need to be
Excellent.
ruled out here.
Yes, excellent. Okay. Okay, let's go to the investigation you mentioned, right? So, okay, how you manage this patient after
So
multidisciplinary team approach? Yes,
yeah,
you told me
exactly.
about this.
So the non-pharmacological part is to educate the patient about the
Mhm,
importance of the antipsoriatic medications to control his
mhm.
disease, and about the 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 fact that he needs to. It's an inflammatory disease, so resting might make it worse. The patient needs occupation support. He might need some walking aid to rest the joint. Um, and he will need to be referred to some social workers, dermatology consultants and rheumatological consultants, plus or minus TNO. We might need to give him IV antibiotics if it's proven that he have infection. Regarding the possibility of gouty arthritis, if it's proven to be gouty arthritis, then we need to change the thiazide diuretic. Advice on smoking cessation, alcohol withdrawal, alcohol stopping, and weight loss if needed.
Okay. In the acute attack, will you start uricosuritic medication?
In the acute attack, I will start with non-steroidal anti-inflammatory medications because it worked for him last time. So I
Mhm.
think ibuprofen should work.
Okay. Yeah, you're right.
But I would give him 2 to 3 weeks before starting allopurinol, if that's what you mean.
Yeah, excellent. Okay.
Yeah.
And if the patient already on allopurinol, will
He
you
can
stop it?
continue the allopurinol if he had
Yeah.
the attack during, yeah.
So this is for prevention, right?
Mm-hmm.
Okay. Uh, any surgical or other intervention you could do to this joint?
So as I said, aspiration, firstly, to just confirm the diagnosis for histopathology and culture. Sorry, biochemistry and culture. And the least
Yeah.
the last option in the list would be replacement, which can happen sometimes.
So what's called this swelling? What's called the swelling in the foot? What you call it?
The swelling in the foot, isn't it?
Yeah.
It was a metatarsophalangeal joint. So
Yeah. I mean the collection. This collection is it? What's called?
to effusion, joint effusion.
To
I don't know.
to five to five
Toffee.
Oh,
to
toffee.
to five
Isn't the
or
toffee is
toffee
the skin rash? To have toffee, you need to have the skin rash,
five.
right?
No. Any redness or any swelling, it could be to five. Yeah. Precipitation of the uric acid. Okay. Will you inject steroids intraarticular? Is it one of the line?
I need to prove
Yeah,
that there
it's
is no
not
infection.
excellent. So to rule out, yes, to rule out the septic arthritis
And I
by
think
doing
because he
aspiration.
have a flare of psoriatic arthritis, IM steroids
Yeah,
would work
it's
better than intraarticular because it will work in the joint and in the rash as well.
yeah. Okay. So last question. What do you think the cause of precipitation of this, I mean the joint pain and to five formation in this patient? Give me three underlying cause.
It can be, do you mean like a chronic inflammation causing like the gouty arthritis, for example, or
Why the uric acid here is high in this patient? Give me
thiazide,
excellent. This is one. The second one.
yeah, hypertension and alcohol,
Excellent. This is the second one. The third one.
alcohol, weight,
Yeah, alcohol second. Alcohol,
hypertension,
thiazide, alcohol, thiazide, and
hypertension.
psoriasis.
Oh,
The
itself. Mm,
the cells itself. Yeah,
mm.
yeah. Okay. So yes, you reached to the diagnosis, non-steroidal as well. Yes. Okay. Let's comment first on Dr. Mrima's performance. Actually, you did it very well. You reached to the diagnosis and you roll out the association, you roll out the cause, and you conclude what the precipitating factor in this patient. The only question you miss about the thiazide, did he increase the dose of thiazide? He might
Mm,
increase, and this is the one precipitating his factor. Yes,
yeah.
he was on one tablet and he increased the dose recently. That's why he had
Mm,
the flare up of gouty arthritis. Okay, so we'll start from the beginning. Onset, course, duration, you asked, and even the side, you didn't ask about the side, but you asked for the pictures. That's why you guess it's in the left side. Yeah, but try
mm,
to ask it. Then the relation to the movement, but you mention it in the management that it will be worse with the rest and it
rest,
will
yeah.
improve with the movement. Yeah, so it's
Mm,
inflammatory one, but better to analyze it in the beginning to know
mm,
if it is inflammatory or mechanical. However, by the picture, it's conclusive. You can know from the picture itself. The CNSI, you ask the history, cardiovascular, chest, GI, endocrine. You miss the endocrine. It's okay. It's not important in this patient. Genitourinary, you ask, but I prefer to add further question for the renal stone. Did you have any passing
mm.
stone
Yes.
recently?
Yeah, you're
Yeah,
right. Very important.
yeah. And in this case, very important about the diet habits. How is your diet habit? Are you taking high beef or high protein diet or seeds? All these will also precipitate the high uric acid in the body. If there is family history of this condition, what you think about? I mean the gout itself.
Family history, metabolic syndrome, you mean, or
Could be metabolic as high uric acid. Yes, Leishman syndrome as high uric acid in the blood, and it will be presented earlier by the uric acid, either renal stones or can be as gouty arthritis. Leishman syndrome, yes. Let's go to the constitutional symptoms. You did it. You covered the fever, weight loss, lumps and bumps, the skin, and I give you the skin rash history, joint. Yes, there is a joint affection in the gouty arthritis joint, in the big two, I mean. Family history, travel history, and the medical history, surgical allergic. The medical, I prefer to ask more about thiazide. Okay.
Okay.
Yeah, you ask when and are you compliant and when did you increase the dose? Methotrexate, I stopped it because it's not effective, but I must be on the methotrexate because it will control my psoriasis. Okay, the HIV in this patient, you might ask only about the casual relationships in case of thinking about gonococcal or septic or reactive arthritis. You didn't touch this point at all. Just one question about the partner and the casual relationship to rule out any reactive arthritis. It's important as well. But it's okay if you don't. Try to always remember the HIV by some questions, the casual relationships, using or sharing needles, recreational drugs. Okay, job, you cover the smoking, alcohol, driving, you offer support and help. Examination was targeting the patient look, feel, move, and the gout. Then the psoriatic, you discover the scalp area and the nail change. Apart from this, you will not find any finding in the patient. Our differential, as you mentioned, so gouty arthritis, psoriatic arthritis, since he's having psoriasis, and septic arthritis of any arthritis should be rolled out and should be in our differential diagnosis. So you did great, Dr. Rimas, as usual.
Thank
Was
you.
perfect. Yeah.
Mm.
Thanks for the performance and thanks for the case you gave to me.
Thank you so much for the case. Yeah, it was
yeah.
very.
Yeah. Thank you
It's
all.
nice
Let's
because I get exposed to cases here every day.
yes.
And it's very nice. Yeah. Thank you so much.
Yeah, always the case you present, if you face it in the exam, you will be perfect and you will show the examiner the best of your performance. When you repeat it in the exam, it will be the best. I
Inshallah.
swear for that. Yeah, especially if you practice it before. Okay, let's inshallah hope that pass and success all of us.
Thank you. Inshallah.
Inshallah, disease itself due metabolic syndrome, yes, important. Podagra to fight. Okay, let's start from here. Disease itself, non-steroidal as well, high temperature, new guidelines. New guidelines now to start both allopurinol and colchicine during attack. Okay, Dr. Fahad, you can share the guidelines if changed, because what I know, allopurinol to be started after, but if you have guidelines changed, you can share it with us. Dr. Roda, avoid non-steroidal in psoriasis, better use colchicine for gouty. Non-steroidal to be used first line, but if there is kidney affection, you can use colchicine. HIV-induced psoriasis. What do you mean by HIV-induced psoriasis, Dr. Roda? You can explain more. You mean
Yes, Assalamu alaikum.
Alaikum assalam wa rahmatullah. Yes, please. You
Yes,
mean worse the
HIV, one
condition?
of the risk factor of the psoriasis precipitation.
Okay. You mean
Yeah.
the disease?
Yes, it like exacerbates psoriasis.
Okay. Okay.
So that's it.
Yeah, if you put psoriasis in the patient differential, yes, you're right. Okay. First line treatment, allopurinol. Second line, febuxostat. Third line, uricase. Pegloticase, Dr. Abbas. I can promise you, Dr. Abbas, the examiner will not know the third line, as well as I'm reading difficulty. Uricase I remember, but pegloticase very difficult. Anyway, febuxostat, I remember it was indicated when the patient has TIMT, isn't TIMT deficiency or activity, TIMT enzyme activity, or something like that.
Yeah, sometimes allopurinol is contraindicated, so
Yeah,
the second line will be febugostat.
yeah,
It doesn't work, then you go for uricase or pegloticase. That's from
okay.
Basmodestin part 2.
Yeah, I agree. It's yeah, written part. But tell me about the enzyme deficiency when you to start febuxostat. There is some enzyme,
TBMT.
yeah, TBMT. Yeah, I know that. I know the abbreviation, but I want the name.
It's very difficult. If you remember TBMT, they will
Okay,
they will not push you.
okay. Yes, I know. It's difficult to remember. Okay. Yeah,
I
if you
think
have
it's
deficiency in this enzyme, yeah, better not
yeah,
to start allopurinol, and the febuxostat will be the alternative. Yes.
yes.
Okay, Dr. Muhammad. Thank you, Dr. Abbas. Thank you so much. Uricase and pegloticase. Okay. Which syndrome associated with gout? Leishman, you mean? Leishman syndrome? It's familiar condition. Yeah, Leishman syndrome. Dr. Ihda answered you. Leishman syndrome. Thiopurine methyl transferase enzyme. Dr. Ihda, thank you. Always sharing what we are missing. Thiopurine methyl transferase. So in case of this enzyme deficiency, we will start febuxostat. Any other comment, any other question before moving to the communication?
Thank you, Dr. Basim. It is an
Thank you.
important of safety of the patient. This psoriatic rash is not improving. Why? Because the patient is using painkiller ibuprofen. Ibuprofen should be stopped as soon as possible because one of the most triggering factor of psoriasis rash, psoriatic rash,
Okay. So
non-steroidal
it was
anti-inflammatory. Yes.
it was the uric
Yes.
acid, as I mean
It's
gouty arthritis,
the
and it
rash.
was the psoriasis itself. Yes. Yeah. Okay. Thanks for
Yes.
the information. For the psoriatic, what the management, the best or the drug of choice in the psoriatic arthritis? Anyone can answer, Dr. Imaz, or anyone. It's okay, anyone.
Methotrexate.
Yeah, methotrexate. Yeah. Okay, and don't forget the topical one, the topical
So
medication
the
for,
psoriatic arthritis, we treat it just like rheumatoid arthritis. So we start with the steroids and then steroid spacing agent. So we give them DMARDs, the methotrexate, and we can give them azathioprine as well and mycophenolate, and then we can move to biologics if it didn't work.
yeah.
Just like the rheumatoid arthritis.
But don't forget vitamin D and the topical
Yes,
one.
very important.
Yeah.
Yes.
But
And obviously education about the sun and everything. I forgot about
yeah,
this.
yes. Okay, thanks, Dr. Imaz. If no more comments, we can move to the communication. Dr. Tanya and Dr. Tanvir. Dr. Tanya, Dr. Tanvir. Okay, Dr. Tanvir is here. Dr. Tanvir?
Yes, Dr. Yes, I'm here.
Yeah, okay. Wait a second, I will message Dr. Tanya. And as usual, if Dr. Tanya didn't attend, we will call our Dr. Rhoda to do the communication with you. Okay, Dr.
Okay,
Rhoda,
okay.
I will message her. She will answer. The message, I messaged Dr. Tanya, but the message not, she's not receiving the message. So I guess she has some also internet problem. So let's start with Dr. Oda and Dr. Tanvir for the sake of the time. Yeah, Dr.
Alright.
Oda, please. Yes,
Okay,
you can start.
okay, I will. Can he give me the case first?
Dr. Tanvir, please give the case to
Yes, yes.
Dr.
Dr. Huda,
Oda.
want to do first, the candidate. Okay,
Yeah,
okay.
she will do
Okay,
the case first as candidate.
okay, okay. Okay, I'm sharing in the group. Okay.
Thank you.
Yes, did you see in the group?
Yes, I see.
Yes, I will share it here
Okay.
in the chat box. You can read it loudly, Dr. Yeah, you can see it, Dr. Rhoda. Can you read
Oh,
it
okay.
loudly?
Sure. Mr. Jack, 45-year-old, he has been working in shipyards for the last 10 years. He has been complaining of cough and loss of weight for the last 2 months. CT chest, abdomen, and pelvis done for him, and diagnosis of diffuse mesothelioma with mets to the liver has been confirmed. You are the senior house officer in the medical department. You have been asked to discuss the result with Mr. Jack.
Okay, 2 minutes, then we can start.
Yes, hello.
Yeah, ready?
Yeah, yeah.
Yes, doctor.
Yes, hello there.
Yes.
I'm Dr. Zain, a senior house officer in the medical department. Just to confirm, am I talking to Mr. Jack, 45-year-old?
Yes, doctor.
Mr. Jack, we are here to discuss issues related to your health condition. Is that okay?
That's okay, doctor.
Yeah. Before starting, do you want anyone to attend the meeting with us?
No, it's okay, doctor.
Yeah. At any point, if you have any kind of concern, just let me know, okay?
Okay.
So to be in the same page, how far do you know about your health condition?
Doctor, actually, I'm suffering from cough and I'm feeling tired. I'm feeling that my weight is losing for last
Hmm.
2 months. Actually, I'm really worried what happened with me.
I'm really sorry for that. And how do you feel right now?
I'm actually a little depressed, doctor.
I'm really sorry for that. And what do you expect would be the cause?
I'm actually worried that what happened with me, it's something infection or what happened.
So thank you for sharing this information with me. As I understand that you have been complaining of cough, shortness of breath, and this has happened recently for the last 2 months. And imaging for your body done. And actually, the result now is between my hands. And I'm really sorry because I'm carrying bad news for you today.
Why you are worried, doctor? What happened with me?
It showed that you have a cancer, Mr. Jack.
Cancer? How it's
Yeah,
happened? Because I have simple cough and tiredness.
I'm really sorry for that. We checked it. It's for you. It is not a kind of infection. It is a cancer, Mr. Jack.
I'm really upset, doctor. I don't expect like these things.
And are you able to continue?
Yes, doctor. Let's continue.
Yeah. Do you want me to explain further?
Yes, I want explanation.
Yeah. It shows that you have a cancer in the layers that cover our lung. And we call this cancer, we call it a mesothelioma. And, um, and I'm really sorry for delivering this kind of information for you today. And this cancer could be related to a being subjected to a specific substance that could be faced. It, it could be related to a substance that could be like you face during people job, for example. And I'm gonna ask you in a minute. And actually, I'm carrying another bad news for you today.
What bad news more?
It showed that it is advanced and it is already reached the liver.
Palliative? What is that palliative?
Not palliative. I said it's already advanced and reached to your liver. Are you with me?
Mhm. Yes, doctor.
And I'm really sorry for delivering this kind of bad news for you today.
It's really upsetting for me that I have cancer and also it's spread to other organ. I'm really upset, doctor.
Um, then um, actually when and this leading to the symptom that you have like cough and shortness of breath and so on. And regarding the plan of management, we are going to treat you in a group of specialized doctors, including the cancer doctor, lung doctor, specialized nurse. We call it a Macmillan nurse. And Also, we will include what is called as a palliative care team. Have you heard about it?
No, doctor. What is this?
Okay, do you want me to explain?
Okay, tell me.
Okay. Palliative care team. I don't. I don't think I could continue, Dr. Basim, because of my son.
Okay, Dr. Radai. You can go ahead with the explanation of this palliative team. Okay. Thanks for Dr. Roda. I will assume the scenario instead of Dr. Roda. Let me explain more about this palliative team, Mr. Jack. Is that okay for you?
Okay.
Okay, so this palliative team is that the professional team concerned to your condition, and they are the one helping you, and they will be managing you in the coming days in your life, being sure that you will not suffer from any infection, from any depression. They will not let you suffer from any pain, from any dehydration, and they will give you the maximum support and care you might need in your life. Are you following me?
Yes, doctor.
Okay. You have any concern so far, Mr. Jack?
So, doctor, there, like what you said, so there is no treatment, like I cannot cure at all totally.
I appreciate your concern, Mr. Jack. Actually, since the cancer cells spread to your body, including the liver and some other organs, and this type of cancer known as aggressive one, and it's whatever we are treating, it's coming back and always recurrent one. So we try to support you with the palliative team management, and let's see what they will decide for you. And according to their plan, we will update you what they will do with you. Is that okay for you?
Yes, I understand, but how many days I will live, doctor? I'm
I
going
appreciate your
today.
I appreciate your concern. I'm afraid to say, yeah, the cancer and the spread of cancer making your life short compared to other persons. I'm sorry to say that, Mr. Jack, but be sure that we will not let you alone in this journey, and we will support you as much as we can in your uh, coming days, and we will be sure that you will not need any support, and we will support you with anything you need. Is that okay?
Okay.
So back to your job, Mr. Jack. Since your job was on the shipyard and you were exposed to a substance called asbestosis, it's a substance present in that factory. Did you work in the company?
No, I'm working, doctor, at the shipyard. I was
Yeah,
working
it was.
there.
Yeah, it was sponsored by the company, I mean.
Yes, yes.
Yeah. So you have the right to ask for compensation, Mr. Jack, because since the exposure to this substance may be the reason of your cancer in the lungs layers. So I can guide you to the office responsible for that, and they can update you about the process of this compensation. Is that okay?
Okay. Okay, doctor.
Yeah. Yeah, be sure that they will support you and they will provide you the paper, the process of this compensation. They are called legal advice.
Okay, doctor.
Okay, you have any concern, Mr. Jack?
Yes, doctor. No, I have no more concern.
Okay, Mr. Jack, are you willing to do something or you have any wishes in your life you want to do?
No, I want actually like proper treatment, or as you said, like palliative treatment. I want that treatment properly.
Okay, so we will update you with the team, a meeting with our palliative team, our professional palliative team. They will sit with you and update you about the management plan. And I will provide you with some leaflet brochures and website about this cancer. You can read about and about also what's called palliative management plan. You can read about in this leaflet. Is that okay? Thank you for your
Okay,
time.
doctor. Okay,
Okay,
doctor.
so
Thank you.
time is up.
Okay.
Yeah, give comment first to Dr. Roda for the first 5 minutes.
Okay.
Then, okay.
Okay, actually, this is a case of the breaking bad news. Like there is some agenda here. You did it well. There is a breaking bad news first for the mesothelioma. So, and during the breaking bad news, Dr. Huda did well. That slowly, by warning shot, by silence,
Yeah,
she said about that mesothelioma. And after that, she explained about the mesothelioma. This is a cancer of the lining of the lungs. And usually, I already said about my symptom. She also asked me that one about my knowledge.
yeah,
And later, she said that how she will manage that. Here, actually, like palliative care, it's okay, but also we need to include that we need to send you the multidisciplinary team. Under the multidisciplinary team, there is a cancer doctor, Macmillan nurse, and also as you are depressed now, so we will send to you mood doctor, and also we will ask for social help, social worker. So with the
yeah,
palliative care, we need multidisciplinary approach because patient has actually now already he heard the bad news, and also he's psychologically upset, and also we need some other department included here.
yeah,
And also, like, yes, that palliative treatment, you said about the palliative treatment, but also need to tell, yes, our oncology doctor, they will discuss regarding with you regarding the further other management is there is other possible option like that.
yeah,
And yes, the important another thing is here. So first is breaking bad news, later about the management, especially the palliative care, as patient got the metastasis. And also the important thing is here that industrial injury disablement benefit compensation, I mean. So here you said, you asked, yes, this is because patient worked in the shipyard for last 10 years. So due to asbestos exposure, possibly he developed this penicillin for these things that we will give, we will send to the social care worker. There you will get we will give you that claim form. So you can claim for the compensation so that medical advisor, he will assess you and he will decide that how much benefit, I mean, how much financial benefit you will get from this. And if you're not satisfied after what they decided, if you're not satisfied, you can also ask regarding the more compensation by the lawyer, so you can claim. So first you will see that how much you will get. So empathy, sympathy, yes, you did good well into the sympathy, and also need to when you are telling that empathy and sympathy and breaking bad news at the same time, you need to tell that yes, we will give you full support, full care, and to make your life more comfortable, pain-free, and stress-free like that. And
yeah,
so here, actually, you need to ask some other social point. Maybe you forget that you need to ask that with whom you are living, anybody
yeah,
supporting you,
yes, you're
because
right.
in the case of like patient already developed the malignancy, so we need a good home support with whom
Yeah,
he is living and he is financially supported, and now he is doing anything for daily meet his expense or something. And so we can involve the social worker to you. And also, like you ask about that advance directive, also need to ask about the everlasting power of attorney, like it's
mhm,
like condition works. So anybody
yeah,
will take any decision instead of him. So like that, and you said last day that yes, we should listen it, and also we'll give you our contact number. So in case of any
yeah,
query or anything, you can contact with us. And if you have time, you can ask that somebody what he get, what he understand from our today's discussion, like that. You can just check understanding like that.
Yes.
It's okay.
Yeah. Thank you, Dr.
That's all.
Tanvir. Yeah. Thanks for the scenario. Thanks, Dr. Rhoda. I hope you hear the comment, Dr. Rhoda. I will add only for the comment. When he was shocked by your breaking bad news, try to offer him some tissue or some
Tissue,
water.
water.
Yeah, yeah, yeah. Instead of asking him, "Are you able to continue?" Just tell him, "We are here. We will support you. Don't worry," and offer him the tissue or glass of water if he wants. What I wrote here too for Dr. Rhoda. Yeah, try to make the bad news together because you made a gap between both bad news by offering the compensation. So instead of doing that, you can explain in the same time you have a cancer in the lining of your lungs, and I'm afraid to say it's also spread to another organ in your body. So it will be shocking one time. Instead of asking for the compensation, then back to the spread to the other one, other organ. So make it as one shot, as Dr. Tanvir said, and offer the help after that and the golden silence. You did it great in the golden silence. The introduction, the invitation, very great beginning because he might need support. The knowledge expectation, yeah, you did well, as Dr. Tanvir also said. The palliative team. So I will just comment on Dr. Rhoda the first part. Then I was continued instead of her because some family issue. Dr. Rhoda, are you there? You can go ahead with the second scenario, or you still have some family issue? Wait, if she's away. Sorry, I guess she's not with us. She left the meeting. Okay, so I will give you a scenario, Dr. Tanvir, from
Okay.
me. Yeah. Just give me some seconds to prepare it or to bring.
Okay.
Dr. Tanvir, you can read the scenario loudly, please, to be clear for you and others. I put it in the chat box.
Yeah. Yes, already. Miss Mona, 55 years old, was admitted 2 days ago after extensive ischemic stroke with the left-sided weakness. And 24 hours after admission, her condition was deteriorated and went into what went into
Coma, into
coma,
coma.
okay.
Yeah,
And repeated CT
brain.
PETs did not reveal any internal changes. Since day one of admission, she received aspirin in the best interest of her condition and pantoprazole for peptic ulcer protection. Her daughter, Miss Laila, is very anxious because of deterioration of her mother's condition. She is very angry because of aspirin therapy, as her mother had history of upper GI bleeding 2 years ago as a result of aspirin. You are senior health officer of the medical department on court today. You have been asked to discuss the issue with Miss Laila. Okay,
Okay, 2 minutes,
so
then
I
we can
just
start.
need two minutes. Okay.
Yes, sure. Are you ready, Dr. Tanvir?
Yes, doctor.
Okay, let's start.
Okay. Hello, madam. I am Dr. Ali, one of the doctors in this clinic today. Are you Miss Laila, daughter of Miss
Yes,
Mona, 65 years old?
yeah, doctor, I am.
Okay, Miss Laila, I think you're the next to the king, Miss Mona. Is it all
Yes,
right?
doctor. Yeah,
Okay, I assume that you take permission from Miss Mona to talk with you regarding her health condition.
yes, doctor.
Uh, okay. So, Miss Mona, today I came here to discuss regarding your mother's health condition. So can you tell me that what you know about your mother's health condition?
What I know, doctor, she had some weakness in her body, the left side. Then,
Mhm.
yeah, she felt unable to stand up, so I called the ambulance and I
Mhm.
brought her to the hospital.
Mhm.
Then, in the hospital, they told me it might be a stroke. Then you
Mhm.
admit her, doctor, and I'm here to listen to you and to hear more about her condition.
Mhm. Okay, Miss Mona, Miss Lala, I highly appreciate your concern, and I understand that you love your mother more. And actually, as you said that your mother suspecting of the stroke and there is a weakness on the left side of the body. Do you have any idea about the stroke?
Yes, doctor, I read about internet in this day. The stroke is like there's something a blood clot in the channel, a blood channel in
Mm-hmm.
her brain.
Mm-hmm.
That's it, doctor. But yeah, that's what I know, doctor.
Yes, I'm highly appreciating your knowledge. Yes, you're right that a stroke can happen due to sometimes due to blood clot and sometimes due to the blood cable, I mean the blood vessel rupture. So for your mother, it's happened actually due to the we assume that this is due to the blood clot and there is a reduced blood supply in the brain, and that's why actually weakness happened in the left side of the body. And at that time, we did also repeat CT, and this is the good news that there is a no more new changes. And at that time, we gave your mother, there is a one medicine we are calling it aspirin. It's a one type of the blood thinning medication, and this is to protect your mother from the stroke. Are you getting?
So, doctor, what do you mean by her condition change?
No, that time actually, as your mother came with the left-sided weakness, and
Yeah,
we
this
assumed
what I know.
it was
Yes.
stroke. Yes. And we did actually repeat CT, and that time we did not found any other changes. And but we gave aspirin a blood thinner. We are calling that medication aspirin to for the best interest of your mother to protect the complication from that stroke.
Oh my God, doctor, you give her aspirin, doctor.
Yes, actually, we gave her aspirin, and just I want to also assure that yes, with that aspirin, we gave other medication for stomach protection. We called it pantoprazole. So we gave the same time for stomach protection and for the best interest purpose for your mother, we gave that blood thinning medication.
Doctor, you know that my mom had problem with this aspirin before.
Mhm.
She was taking this aspirin and she bleed a lot because of this aspirin for her stomach. And now you
Mhm.
are giving her aspirin? Are you serious,
Yes,
doctor?
I understand your mental situation, Miss Laila, but I just want to assure you that actually aspirin given for the best interest of the mother to prevent the further complication related with the stroke. And as we suspect the stroke, and also your mother came with the feature of the stroke, so for the best interest, because if we think that is every medicine has there is some side effect, but if we compare about the benefit and the side effect, so the here the aspirin giving aspirin is has more benefit than not to give. And I just want to assure that yes, I understand you love your mother more, and your mother has history of there in the stomach bleeding. But I want to assure that we also give the stomach protection to prevent the bleeding. And also, I just want to inform you that we are doing regular follow-up, and who are we are seeing or we are taking care of your mother. There is some stomach consultant, and some other physician, specialist nurse. So we are regularly following your mother. If anything happen, and we can do our best. Are you getting?
Yeah, doctor. But I still am worried, doctor. It might bleed again, doctor. So, doctor,
Mhm.
you have
Mhm.
you should give me guarantee, doctor, that she will not bleed again, doctor.
I'm highly appreciating your concern, Ms. Lala. I understand that you're too much worried about your mother's condition. Actually, we cannot give the guarantee, honestly, I'm telling. But we will give the best support, best follow-up, and we are regularly follow up if there any bleeding or any bleeding related complication happen or not. If anything happen, you can get the best support accordingly. Because we have here our stomach doctor, I mean, we are calling it gastroenterologist, specialist nurse. Also, there is a social worker, and also we have other physician and even your GP. So we are regularly follow upping your mother, and if there is any chance of the bleeding or any symptom of the bleeding, we will give the best support. And also there is a lots of medication to protect the stomach ulceration. So we will also apply that, and we will regular follow up your mother. Are you getting
I
me?
hope I hope so, doctor. So okay, doctor. So no choice, doctor. No other alternative medicine to give.
Actually, as I said you that that time we gave aspirin for the best interest for your mother, and we will apply some other medication for the stomach protection. Already we get, and we have other medication, even the injectable form medication for more protection according to your mother's condition. Is
Okay,
it
doctor.
is it understandable?
Yeah, doctor, I understood.
Okay, Bismillah, just I want to know some other things about your mother. Actually, in your house, your mother living with whom? Is there anybody
Yeah, with
supporting?
me, doctor. I am always with her. I am supporting her.
Okay, okay. So your mother now doing anything for living or she retired?
No, doctor, she's staying at home. She's not working.
Okay, okay, okay. So as you know that your mother has already that also previously, so I think you know that some food there is a restriction for the stomach ulcer if have somebody.
Y-
Do,
You
do,
mean,
do you
doctor?
know?
Yeah, you mean she will not be able again to move?
No, no, I'm asking that for if there is somebody has a stomach problem with that stomach ulceration or bleeding, so there is some food and some lifestyle modification need. Do you know about that?
No, doctor.
Okay, so we will involve the dietitian and social worker so to make a proper chart for to control the stomach bleeding, and also social worker, and also we can involve the physiotherapist who can give the best support to your mother. Is it okay?
Okay, doctor. Thank you for that.
Okay, I just want to know that it was some personal question about your mother, if you don't mind.
Yeah,
That that she is doing a smoke.
sorry.
She is doing a smoke.
No, doctor, she is not.
Okay, she's taking alcohol.
She quit, doctor. She is not drinking anymore.
Okay, it's good. So we will involve that our brain doctor and also your GP, and there is a specialist nurse, occupational health, social health worker, so to give her best support. Is it okay for you?
Okay, doctor.
Okay. Do you have any more concern?
Doctor, when my mom will go back to her home?
Actually, it's depends upon her physical condition and response to the treatment. And now for the time being, we admitted her, and we will regular follow up, and we will see if there any chances of the bleeding or not, and how much she improved from this weakness. And according to the condition, we will discharge her.
Okay, doctor.
Okay, I will give you some leaflet and brochure and a website number. You can read it about the
Okay.
situation, and also we will give our contact number so you can contact anytime.
Thank you, doctor.
Do you have any other query?
No, doctor. Thank you. So time is
Can
up.
you take?
Okay. Okay, Dr. Tanvi, thank you. You did great, actually, from the beginning till the end. Just I will comment for the others, just to have the idea how
Mhm,
to the scenario to be derived.
mhm.
You did it all right. So the introduction, permission, as you mentioned from the mother, you assume that what you know, Miss Layla, about mother condition, and the expectation. Better to ask what's you
Yes,
expecting.
yes.
Yeah, yeah, always missing the expectation. I explained to you the clot and the blood channel and so on. But you did not update me about the last condition that she went in coma. That's why you repeated CT. I guess you didn't update, or you did that. I didn't hear well.
I
That
did not tell about the coma. Yes.
yeah, because yeah, it's in the scenario. I was waiting to ask me
Mhm.
what you know further, so I will tell
Mhm.
you I don't know what happened, why she's not talking with
Mhm.
me, doctor. I waited for you to explain, but you did just
Actually, you did not ask me about why she is not
yeah,
talking. If you
yeah,
asked me
yeah.
that time, I told you he is in the
So it's supposed to
coma
be
state.
from my side as well as from your side. So it's yeah, either
Yes,
by
yes.
me or by you. So to tell me that the stroke being complicated and she's not talking more and
Uh-huh.
she's in coma. That's why you repeated the CT. You mentioned the CT,
Yes,
but you didn't tell me why. Okay, this is the
yes,
missing point.
yes.
The aspirin started in the best interest for your mother, and you assured me that we started the stomach protection and oh my God, doctor, you will start aspirin for my mother, and she had a history of bleeding from the stomach. You reassure me again that it's not, it's already started on the PPI, which is called the stomach protection, and you involve nicely the team of stomach doctor specialist and the gastro team, you mean, to follow up here if in case of and you reassure me again about the follow-up and the monitoring of the blood counts in case of developing any decrease in the blood count. We will be managing here as soon as possible, and you reassure me again. The guarantee of bleeding as a concern, you answer it perfect. You told me no guarantee for that because even with PPI, it might bleed. However, we will be there and we will follow up here and we will do our best to prevent this complication from happening. Then you give me the leaflet brochures, but I wished if you ask me about advanced directive and lasting power of attorney because she's not in her conscious level anymore, and yeah, she might not wake up again. And you
Mhm.
offer me the support, and you ask me for the
Mhm.
dependent. Yeah, that's it. So the advanced directive only this point missing,
Yes, yes.
and yeah, the comma
Actually, I'm
update.
missing that comma point.
It's okay. Yeah, it's okay, Doctor. The other, apart
I
from
don't
this,
have
you did
speech.
great
Yeah.
as usual. No, it's okay.
Thank thank you,
Yeah.
doctor.
So every word in the scenario means uh, there is aim for this word. Yeah.
Okay, just I have
Don't.
one confusion
Yeah. Yeah. Sure.
that
Sure.
as you said that after 24-hour admission now deteriorated and went to coma. And repeat CT done, brain done, and did not reveal any interval change. It means that CT is not improving, like same
Yeah.
condition, ischemic changes. There is a no feature of the improvement. Is it? Is it you mean?
Yeah. 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 No
Uh,
improvement, and
no
the
improvement?
com
Yes,
and the radiology it shows the same picture.
same
But
picture like before.
the clinical, yeah, the clinical sometimes worse, even with the progress of the stroke, even
Yes,
the image is still the same. Yeah.
yes, yes. Okay, thank you.
Okay. Thank you, Dr. Tanvir. Thank you for being with
Thank
us
you.
today. Yeah.
Thank you,
Yeah,
doctor.
you're always welcome to practice anytime with us, as you
Thank you,
are
doctor.
one of our colleague, and you are always sharing with us the practice. We hope to
Thank you,
meet with you again. Okay.
thank you,
Thanks.
doctor.
Thank you. Any comments from other, any point to be discussed, any question, any inquiry? Everything was clear today for the long consultation scenario, for the communication, any question? So if no, we can stop recording for nominating for tomorrow participants. Thanks all. See you tomorrow.